Okay, on now to a clinical presentation. This is a first patient who presented at the age of 4 years with a squint and was noted to have 6 cafe au lait patches, was already hypertensive, and the main reason for presentation, apart from the squint, was that she had failing vision. An MRI was performed, and this showed, not surprisingly, bilateral, thickened and tortuous optic nerves consistent with optic pathway gliomas. In addition, this patient had high signal in both thalami, basal ganglia, and this is probably not neurofibromatosis like objects because this is a T1 weighted image, and these are high signal occupying some space. So these are probably low-grade astrocytic lesions as well. So although I'm not going to talk to you in detail about the management of optic pathway tumours, it's appropriate just to talk a little bit about them here. 5% of children's brain tumours are optic pathway gliomas. Half of these patients have neurofibromatosis. Most of them present under the age of 5, and almost all of them present by the age of 10 years old. And importantly, any part of the optic tract can be affected. So here's a picture of a patient who's got a thickened optic nerve within the orbit, but also high signal lesions in the optic pathway leading to the optic radiation. The symptoms are, as might be expected, visual loss. They can also be proptosis if the tumour presents within the orbit. Squint, strabismus, and nystagmus may also be seen in anybody who's got failing vision. When children are very young, they may not present with very specific symptoms, and they may simply show developmental problems, not hitting developmental milestones. Occasionally they present with this unusual syndrome known as diencephalic syndrome, particularly in patients who have hypothalamic astrocytomas. So this is a patient who has evidence of failure to thrive, despite being otherwise looking very well, very active, often with very hyper-alert features. And this is a typical presentation of a patient who has a hypothalamic tumour. Also in hypothalamic tumours you may end up having endocrine deficiencies, and of course if tumours get very large you may get associated hydrocephalus. The second part of this slide is probably the most important thing. The overall survival at 5 years is high, but there is significant morbidity from the tumour, but also from the therapy. So one of the main aims of treatment is to do as little as possible. Observation is often the mainstay of management of optic pathway tumours. If you have to, then chemotherapy may be relevant. It's very rare to require surgery, and where possible we like to avoid radiotherapy. So this patient also had hypertension. It's worth just mentioning a little bit about that now. So pheochromocytoma is a cause of hypertension, and it's common in neurofibromatosis, particularly in older patients. There being various series recording of incidences of over 50%. But in addition, you get renovascular complications, and you can get narrowing, you can get coarctation, you can get aneurysms of vessels. And there's this thing called the mid-aortic syndrome, where you get a diffuse narrowing of the middle abdominal aorta. And all of these combine to give a significant risk of early death in patients with NF1. Vasculopathy is not only a narrowing, but you can also end up with ectasias. You can end up with something called moyamoya disease, which is a proliferation of small vessels at sites which have been stenotic, and also of aneurysms. And this is presumably because neurofibromin is expressed in blood vessels, and this is an abnormal response to what may be normal trauma, such as hypertension. Certainly the histological features of many of these abnormal areas is a proliferation of Schwann cells. So the question has to be raised as whether how aggressively one should treat hypertension, or should this be different from the general population. So here's a second story. This is a patient who was diagnosed as an infant with neurofibromatosis and had subsequently been shown to have a small optic pathway tumour, but this was not causing any problems and no treatment had been given. The patient had mild educational problems, but developed a painful wry neck after contact sport, and when they came to hospital was noted to have a lump on the back. The rest of the examination was non-specific, apart from some features of neurofibromatosis like cafe au lait patches. There was some concern that this might be a new tumour arising over the neck, and therefore an MRI was arranged. Somewhat surprisingly, we found this evidence of collapse of a high cervical vertebra, causing significant stenosis of the spinal canal. This is a very difficult situation. The patient had presumably had a collapsed vertebra going through a dysplastic bone and needed urgent management by stabilising it temporarily with a hard collar and then subsequently on traction, and then very soon after underwent a fairly major reconstruction. So skeletal complications can be silent. You may just see X-ray evidence of fibrosis or thinning of the cortex, dural ectasia or dysplasia. The characteristic lesion of neurofibromatosis is said to be tibial bowing, but you can also get pseudarthroses, a mild scoliosis and osteoporosis. Here are some pictures which I downloaded from the net again, showing bowing of long bones of the forearm and of the tibia. Educational problems in the previous patient are common. Many kids with neurofibromatosis have a normal IQ on assessment. The population IQ is probably about 95 rather than 100 in crude terms. But the children often have disproportionately large educational problems. And this is, I think, a sum of many different aspects of different development. So they often have poor spatial judgment. They certainly have visual problems in many cases, either because they can't see because of the optic pathway being affected or because they can't process things properly with their optic cortex. They often have short-term memory, which is very poor, and they're often quite impulsive. Indeed, quite a high proportion of these children have attention deficit hyperactivity disorder. There is some correlation between the number of high signal lesions on T2 and overall IQ, although that's not particularly valuable in terms of estimating one's difficulties. There is also some evidence that different mutations of the neurofibromin gene can affect overall educational problems. Compounding this, many kids have social problems. They find it difficult to pick up non-verbal clues, so they often stand too close. They may try too hard to make friends. They may not recognise facial expression as a means of communication, and the children themselves often have some degree of speech difficulty, sometimes with nasal speech. So these kids can end up being very isolated and need additional support for this. And again, the loss of neurofibromin expression has been associated in models in Drosophila and mice with reduced learning ability, but I'm amused at the prospect of trying to educate Drosophila. Okay, here's the third clinical situation. This was a patient who presented with a leg that had been swollen for many years and had been told that this was a hemangioma. The patient was rather short, consistent with parental height, but only on the second centile. And when they came to hospital, it was noted to have numerous cafe au lait patches, many neuromas palpable over the trunk, and his head circumference was rather large. The MRI that was performed of the leg showed, as expected, abnormalities which are consistent with a plexiform neurofibroma, with very significant disordered enlargement of neuronal tissue, also schwannomatous tissue, and actually a rather small lower limb below that. The patient also had evidence of an optic pathway gliomas with bilateral, tortuous and rather fat optic nerves, and some high signal in the lower brain. So plexiform neurofibroma is a relatively common problem, almost 1 in 5, and typically affects the trunk or the head and neck. There is only a small likelihood of causing malignant change, but it's still there, and if it were to happen, then it can be a very major problem. Histologically, these tumours are full of Schwann cells, fibroblasts and mast cells, and there is evidence of a very high expression of RAS-GTP, so there is a disordered expression of the RAS-GTP pathway. The tumours are highly vascular, and although their growth is typically quite slow, it tends to come and go, so it can grow quite quickly at times and then slow down. They're not invasive as such, but they do tend to cause loss of function, and they can cause erosion of underlying bone or other tissues. The lesions themselves, although firstly often cosmetically not very nice, but also they have often associated skin changes with hyperpigmentation and hairiness overlying it. So again, there's a significant psychosocial component to this problem. And cosmetic removal can be very difficult, particularly in certain areas. So here's just a few examples from the net. This is a plexiform neuroma in a patient who's got a scoliosis associated with it, and here's a patient who, rather like the example I gave you, has a large lesion of the lower limb extending just above the knee. And this is a painting from 160 years ago of a patient with neurofibromatosis who had a similar lesion affecting the face, and here's a more up-to-date example of a patient who, otherwise well and obviously a happy, cheerful chap, is going to have problems because of the cosmetic effect of his tumour. So MPNST, malignant peripheral nerve sheath tumour, sorry, a slight aberration there. MPNST is a possible development from plexiform neurofibromas. Surgical resection of these neurofibromas is problematic and actually may be more difficult and more disfiguring than the tumour themselves, and therefore people have looked to alternatives to things like anti-angiogenic agents with thalidomide or occasionally with low-dose prolonged chemotherapy. None of them yet have been particularly helpful. There was a trial of interferon beta which was performed in the last year, but this trial had to be suspended because of the dose-limiting toxicity of the interferon, which was attention deficit and hyperactivity disorder in these children. There's been a trial of sorafenib, which is a drug used for renal cell carcinoma. It's a multiple inhibitor of many kinases, including RAF kinase, and it was hoped that this might reduce the vascularity of the tumours, but results of these have not been particularly helpful. And people have been looking more recently at things like mTOR inhibitors, which are popular agents in many different tumours. mTOR is the mammalian target of rapamycin, and rapamycin is the original drug used to identify this pathway. So, what about the long term for kids with neurofibromatosis? Well, they're going to have many and quite varied complications. There is a high morbidity for many of these children because of the things that we've talked about. And as a result, many children with neurofibromatosis also have a reduced life expectancy, about 15 years less than the normal population. And this argues, I would say, for having ongoing screening for children into adult life, with prompt attention being paid to complications so that we can reduce the overall mortality and morbidity. There are many opportunities for therapeutic intervention to reduce the complications, and although it shouldn't be an oncologist, the person who is going to follow these kids up is really not well defined in most areas. Anyway, that's my talk. There are many people who know a lot more about neurofibromatosis than me, but I hope this has been helpful. Thank you for listening.